All right, why don't we get started? I hope everybody had a little bite to eat. Thanks for coming. Appreciate everybody coming here. And we're happy to have pickleball players, softball players, and anybody else. Everybody's got a shoulder, and that's what we're talking about tonight. So I'm Dr. Edward Mikol. I'm one of the founding partners here in Carolina Orthopaedics. And we have a treat in store later with the therapist talking to you as well. So we have ATI here with us as well. So let's get right on into it. So this is what I'm going to touch upon. The majority of what we're going to see looking around the room is going to be rotator cuff pathology, but also arthritic conditions affect the shoulder. Dislocations and instability may not be so much in this group, but it is a possibility. Throwing injuries, of course, pickleball, throwing or racket type injuries can all be related. And then we'll go into a few things that can happen there, as well as adhesive capsulitis, so-called frozen shoulder. We'll go into the anatomy a little bit here. We're talking about the shoulder is basically, it consists of three bones, the shoulder girdle. One, the clavicle, the collarbone, the scapula here, which has the acromion attached to it, and the humerus, or the ball of the ball and socket. And then as we go into the anatomy, which you can't see on the x-ray or the drawing on the left, would be showing in particular this tendon here, which is a muscle becoming a tendon. That's part of your rotator cuff, the supraspinatus. That's the one that's most often injured. But you can have pathology in the acromioclavicular joint right up here. You can get a so-called bursitis or tendonitis. This gray structure here would be the bursa. You can have tears in the rotator cuff. You can have partial tears. You can have tendonitis, and we'll try to go into all that stuff, as well as injuries to the glenoid labrum in here. This part here is the socket, the bony part of the socket. And this labrum extends the socket, and that can get torn and cause some injuries, which we'll go into. So the most common symptoms in the shoulder, people come in and say they have pain that runs down their arm. Even though the rotator cuff's up here, you tend to feel it down this way. Now, it may occur at rest, it may occur with activity, it may occur with throwing. A lot of times at night when you're sleeping, it bothers you when you feel it. You may have some weakness. And then there's a lot of people who just don't have any symptoms from the rotator cuff. Pain, or on the examination we see guarding, which is basically you're having pain when we try to move it. And that is sort of a non-specific thing, but it can clue you into what's going on. You have pain with motion. Crepitus is sort of a crunching Rice Krispie type sound that a lot of you probably have felt. I know I have, or heard. And weakness and so-called impingement signs. You'll see me twist your arm in a position something like this. It's not just to torture you, but it's to try to elicit a response that would clue me into what's going on in your shoulder. And that is to compress the rotator cuff here between the acromion above and the bone below, which is the humerus. Right here comes the rotator cuff. It's a muscle becoming a tendon. We're pinching the bursa in there. And that's kind of what we're trying to do to elicit symptoms pointing to that area. As I said, there's a spectrum of injury from bursitis, tendonitis, partial tearing to full thickness tearing. And I'm going to move along a little quickly because we got a lot to cover here. X-rays can be helpful showing abnormalities, but I'll zip through these pretty quickly. One thing I do want to show you is a bone spur in the front here that you see. And when you bring your arm up forward, that bone spur can dig into the front of your arm and get your rotator cuff and irritate you. So it's important to get X-rays. Everybody always wants to get an MRI, but the X-rays show us stuff too. In particular, right here in the middle, this is osteoarthritis, where the ball and socket, the bones are almost touching in there. That's because the cartilage is worn away. That's not a rotator cuff problem, and we probably don't need an MRI for something like that. And then this one on the far right is the long-term effects of a rotator cuff that's not treated. This is what we call rotator cuff tear arthropathy. For various reasons I may get into a little bit. There's an irregular motion to your shoulder when you get a rotator cuff injury, and if the rotator cuff tear gets bigger, eventually you're going to end up with arthritis. So you'll hear us kind of push you toward a surgical treatment if you have a tear. In MRI, everybody likes to see these pictures, is going to show you the muscle, the tendon, the bone. In particular here, this is muscle. As it comes laterally out toward between the acromion above and the humerus below, you're going to find it turns into a tendon, this black structure, and attaches to the bone. These are both normal MRIs, but as we get into it here, the one on the right, you'll see an area where the rotator cuff is inflamed. It has fluid in it. That's what this bright signal is here. And on the left here, there's a true tear. You can see that that black tendon is pulled off the bone, so-called rotator cuff tear. The one on the left here is what you just saw, but then going further on the right, this is an irreparable rotator cuff tear. This is one of those that we could not repair. There's just not enough tendon, and it's probably been around for quite a long time. And that's, the MRI helps us clue you into what we may or may not be able to do to help you. So non-operative treatment, the majority of patients, people who have tendonitis or bursitis, some rotator cuff tears, either somebody who has an irreparable tear or maybe people who are unhealthy. But most rotator cuff tears will get repaired or have surgery one way or another, and especially if you fail conservative care. If you've had shots, injections, therapy, and you're not getting better, even if you don't have a tear, we can fix that with surgery. So non-operative treatment is going to be removal of something that might be irritating it. Maybe that's temporary, you know, maybe you're not throwing for a while, and we let things calm down and get you feeling better before you get back into throwing. Anti-inflammatory medicines orally, home exercise programs, and I can't stress enough, but physical therapy, I have a hard time convincing people sometimes to go. They think you're just doing exercises, show me the sheets, but there's a lot more to it than that, and these guys will get into it in a little bit as well. And then we give injections, and then when I won't get too much into the exercise program because they're going to probably help you on that here. When exercises and conservative care do not work, we'll likely end up talking about doing arthroscopic surgery, and we make small little incisions, usually 3, not exactly what you have here, but something similar. And we puncture under the muscles and get into the joint and or around the rotator cuff, and without damaging the tissues around it, especially the muscles, we can take care of a lot of things such as repairs of rotator cuff. But this would be an example of what we call a decompression, where the space between the acromion above and the rotator cuff below is tight. So we're opening up that space by grinding the bone down with the burr. So here's another picture of it where we're taking out a spur with that burr. It spins and grinds and sucks out the debris through that. You could also do what we call a distal clavicle excision. Sometimes there's spurs where there's an arthritic distal clavicle, and this is an example of that. So we're going to grind out that area, and I'll show you some pictures in here. This is sort of the history, a little bit of how we did rotator cuff repairs. I haven't done the left 2 in years. Everything's arthroscopic for the most part if we're addressing rotator cuffs. Some people still do them that way, but we've graduated from that. In general, what we're going to do is grind down the bone where the graded tuberosity is and burr it down. We're going to put little holes in there, and we're going to put these anchors in the middle. There's some examples of anchors that a company named Arthrex has brought in for us. We tend to use Arthrex instruments here. And then we pass sutures through the rotator cuff and suture it down. If you guys want to take a look later, you can, as to what might be implanted into you. So here's an example of a true picture of a normal rotator cuff attachment on the left and then a hole on the right. It's pretty self-explanatory. We're looking from in the ball and socket up. On the right, we have that same picture of a full thickness tear where it's pulled off. And then in the middle, on the left there, is a partial tear. Think of a rope that's fraying. You know, the rotator cuff has a lot of fibers, and it may start to wear through. And when it frays enough, we repair it. If it's a minor fray, maybe less than 50%, we may leave it alone. But most of the time, it's going to progress. And if we're in there seeing that, we're going to repair it. We're probably going to convert it to something you see on the right and then repair it. So here's a tear looking at it from below up, and then on the right, it's from above down. These are little cannulas. That thing up to the upper right there is a plastic cannula where we insert the instruments. So before and after, this is a little bit of an older picture, but most of the time we'll drill the holes in that bone on the left, pull the rotator cuff down, think of a window shade, pulling it down and reattaching it, and those anchors hold it in place while it's healing. And then we have to protect it while it's healing, and I think therapy might get into that a little bit, telling you what we can and cannot do. So here's an example of a decompression where on the left we've got a lot of bursitis, and then on the right side here, up above, the white tissue here is your acromion, the undersurface of the bone. Then all that scar tissue's out, and below here is a little bit frayed, but it's the rotator cuff. So we've cleaned out all the stuff in there. So the rubbing that would occur is no longer rubbing, and it can let your tendon heal, and you won't have pain, you won't get the inflammation and the tendinitis. There's a bone spur here, and that's been ground off. Over here is the AC joint, where the collarbone is here and the acromion here. And that little gap, there's not much of a gap because it's arthritic. So here we've ground it out, the collarbone on the left, acromion on the right. So post-operatively, no repair of the rotator cuff. In other words, we go in there, we clean up bone spurs, scar tissue, all that kind of stuff. We can come out of the sling anytime. We start therapy right away. First get your motion back, then get strengthening. But it's critical to go to therapy. It really does speed your recovery, and you get a better result ultimately anyway. And so rotator cuff, if it's repaired, it needs to be protected. Everybody hates being in the sling, but it's important. If you're not in it, you're going to just tear everything for sure. And again, you work on motion, strengthening, and physical therapy is critical to that process. Briefly, I'll go into the recovery. It can take 6 months or more for a rotator cuff. Everyone goes at a different pace, but you got to be patient. It's going to take a long time. And people talk to me and say, my friend had shoulder surgery and he had this. But they're not all the same. Don't assume everything's the same. Small tears, large tears, partial tears, irreparable tears, arthritis, no arthritis. So everybody goes at a different pace. You best talk to the surgeon and the doc that did it as to where you should be. And if we're concerned about you not progressing fast enough, we'll get on the therapist there and make them work a little harder. So we'll jump into arthritis. We'll go through that. This is a ball and socket joint, the shoulder. You can see bone spurs in the bottom. There's cysts in the bone here. There's no space between the ball and socket. That is osteoarthritis. I won't go too much into the other arthritis causes, but there's a number of them. Pain, limited motion, grinding sensation, stiffness, and weakness. Sounds like the rotator cuff too, so they're not one is not always the same. And we have to discern and delineate what the different symptoms are and figure out what's going on with you. Our goal with the treatment of arthritis is to get you back your life, whether it's playing pickleball, softball, throwing a javelin, or pitching for the Yankees. I don't care what it is. The goal is to get you back to what you want to do. And as a team approach, we try to do that. We want to get your symptoms down, and anti-inflammatory medications may help that. Non-steroidals like Motrin, ibuprofen, Aleve, Advil, aspirin you can take as well. There's some other drugs in there that you can use sometimes, but injections, it's not, quote, cortisone that we use a different version of that, but they're powerful anti-inflammatory medicines. We inject it for the inflammation around the rotator cuff, we inject it for the inflammation from an arthritic joint. Small risk of infections, but generally you get pretty good relief. When that does not work, we might end up heading towards surgery, but other non-operative treatments are activity modifications. We get you to a stretching and strengthening program, physical therapy. All that stuff can help you because slowly but surely as you get arthritis, your shoulder starts to get stiffer, weaker, and you'd be surprised from where you started to where you end up and how much better you can be with a proper rehabilitation program. So surgical options. Arthroscopic, not too much. We can sometimes go in there and clean it up in younger people, but the truth is you can't go in there and fix the cartilage that's been damaged from an arthritic condition. Most of the time when we do surgery for arthritic conditions, we're talking about replacements of the shoulder in one form or the other. So here's an example of an arthroscopic treatment. This procedure shows, or in this picture, you can see that there's some frayed cartilage, there's some loss of cartilage here. This should be smooth and one nice surface, you know. More like what we see down here, but you can see where it's cracked and fissured and these frayed things, you have a deficit. That's a pretty significant arthritis in that shoulder. At some point, likely going to need a replacement. I don't remember if this was somebody who was younger and just had an injury, but this would be a ball and socket replacement. The one on the upper part is a ball and socket trying to replace a traditional shoulder, and that is done in somebody who has a good rotator cuff. When you get to the point that you don't have a good rotator cuff, we do the one below, which is what we call a reverse total shoulder replacement. And that's up to your surgeon to decide how and when and why. But is it right for you? Well, if you're having a lot of pain with reduced loss of motion, function, quality of life's not good, therapy's not helping, shots aren't helping, you're probably a candidate for it if your problem's arthritis. So again, we have a metal and plastic component with a ball and socket to replace. This metal stem goes down into your humerus bone and resurfaces the joint. So here's a picture of it. And down on the bottom is mostly what we're talking about. There's a socket as well as the stem going into the humerus with the stainless steel ball. This page is a reverse replacement. The drawing in the top shows what happens when you don't have a rotator cuff. The humeral head starts to migrate superiorly toward your head, and it doesn't stay in the socket. That's the function of the rotator cuff, among other things, is to try to keep that ball pegged in the socket. And when you don't have that, the shoulder migrates up, and you get a lot of weakness, and of course it's painful. And this reverse shoulder replacement that we see at the bottom is what we do to treat that, if the other things have failed. But we're looking to restore your mobility, get your lifestyle back, and give yourself the freedom to do the things you want to do. Briefly, we'll go into shoulder dislocations. These are related to subluxations. A dislocation is, frankly, when the shoulder pops out of the socket. And you can see the rotator cuff attached to the front of the shoulder, that's up top, and also to the back. There's a little bit of a tearing in the back there. But as it pops out of the socket, it can also impact and fracture your humeral head. And so you can have damage to other structures. A subluxation is when the shoulder slides in the joint but doesn't pop out too much. You probably won't get much of that in this age group, but in younger pitchers and people like that, they can have loose ligaments that allows the shoulder to kind of get sloppy around in there, causing trouble. A true dislocation, you're going to probably see a deformity. You'll see a ball that's a big prominence generally in the front of your shoulder, but they can pop out the back, the bottom. Weakness, limited motion, and it can be acute or chronic. Believe it or not, you see people who've had shoulders that have dislocated, and they come in and I see them a month later and say, well, I just thought it would get better. And I'm looking at it saying, how are you living like that? You know, it has to hurt pretty much, but I've seen them. But usually we'll treat it by putting it in acutely, either under anesthesia or not, and we'll get it to pop back in. And generally, it's going to do pretty well. However, you can have an associated injury where you get a labral tear here. And this structure that deepens the socket of your shoulder, which we talked about earlier, can get torn off. And sometimes we have to repair those. They don't tend to heal right in the same spot. And if the shoulder becomes unstable, we end up arthroscopically generally repairing that. So initially, it's a closed reduction with or without anesthesia. If we can get to it early, it's easier to get in. Usually we don't need to do open reductions or surgery for it unless people have ignored them. But if treatment is needed, these are in people who have recurrent dislocations. It keeps popping out of joint. You have rotator cuff tears associated with it. And people in the age group we have here, and I include myself in that, when you dislocate first time, a lot of times you're going to have rotator cuff tears, whereas teenagers and people in their 20s, when they dislocate, usually the rotator cuff's not torn. So a lot of times you're going to have rotator cuff tears, and if you pop out a joint, I'm more than likely going to order an MRI on you, suspecting that there's a high incidence of tears. And then the treatment can be arthroscopic or open. Most of the time it's arthroscopic. We'll move on to what we call adhesive capsulitis. People like to call it a frozen shoulder. It's insidious in onset, meaning we don't know what causes it. It just comes on slowly but surely, and people just have trouble, moving their shoulder. It's pretty common. Frequency is frequently the cause is unknown. We don't know why, but it's pretty common. You're unable to reach in general up your back. Maybe your other shoulder goes up your back, but the other one doesn't. And it can affect both sides. When you look into that joint, first of all, treatment is physical therapy, very important. It's very hard to get somebody to do these exercises on their own. They're stiff, they're painful, they don't like to do it, they don't want to do it. But it's slow gains. You may get a couple degrees of motion each time, maybe, and you just keep slowly but surely getting it. You got to beat it back. You got to be patient, and eventually you'll likely do just fine with it. Injections can be done. Sometimes we go to surgery and do a manipulation under anesthesia, or what we call a lysis of adhesions, where we go up and we actually break up some of the tight structures. Think of a suit where, if this is tight and it won't let your arm come up, you have to have it loose enough to be able to move your shoulder, and the ligaments get tight and contracted. This is a picture of a shoulder joint that has that. So it can sometimes require a second surgery and can involve both shoulders. Throwing injuries, not these type where a bat's flying, but Throwing, that includes racket sports. So we're talking whether it's pickleball, throwing softballs, baseballs, javelins, they're kind of similar in their injuries that can occur. Subluxation, dislocation we already went into. Rotator cuff pathology we covered. I'm going to introduce a couple more things. One of them would be biceps tendonitis, but before we do that, I want to talk about throwing. So there's 5 phases: wind up, early cocking, late cocking, acceleration, and follow through. The main ones that are going to get where you're going to feel injuries or get injuries is late cocking, where your arm's back and you're stretching the ligaments in the front of your shoulder. You're bringing your arm way back so that you can come forward and put momentum on the ball and get some speed. But it forces the humeral head forward, and that can damage some of the structures in your shoulder. So that tends to stress the front of the shoulder. And then in follow through, when you let go of the ball, your body has to decelerate that arm. And there's a lot of weight behind it, so a lot of forces. And the structures in the back need to slow down that shoulder, so to pull it back and slow down the rotation of it. And I think Jeff is going to go a little bit into some of that stuff too. So what can you do? You can get, or what can you get? You can get slap tears here. These are superior labrum tears. Orthopedists like acronyms. That stands for superior labrum anterior to posterior. And that structure where the biceps tendon attaches can get torn off. You can also get a biceps tendonitis where the tendon itself is inflamed and irritated, or it's partially torn, or it pops out of this groove in here because this ligament in front has torn. And it can rupture. A lot of people come in with the so-called Popeye deformity, where the muscle, the biceps muscle has ruptured, and like a window shade, it goes whoop, down like this. It's not going to go back on its own. And most of the time, the ruptures we don't need to do anything about, but biceps tendon pathology can be painful. There's something called internal impingement I'll just briefly touch on, and that's when your arm is externally rotated fully. The structures in the back of your shoulder, including the rotator cuff and the labrum, can get torn up. This would probably apply more to Major League Baseball pitchers or people who pitch baseballs frequently. It doesn't have to be Major League. And that's more, it's probably not what we're going to see in this age group. I would expect 99.9% rotator cuff injuries as opposed to something like this. But it can occur. Glenohumeral internal rotation deficits are mostly in pitchers. They tend to lose, if you were to compare the rotation of the shoulder from, this is internal rotation, this is external, the dominant arm that they're throwing with often doesn't rotate fully down like the other one. And that there's a number of reasons for that. I won't go too much into it. It's not only posterior capsular tightness, but it could be actual bony development where the bone is, the humeral head, the ball is rotated backwards relative to where it would normally be. And again, I'm not expecting that to be something we'll see here, but you may see something like this, the so-called sick scapula syndrome. The scapula is held up by your collarbone, and basically everything else on the shoulder blade are muscles. They hold the shoulder blade to your rib cage. And those muscles need to function normally in concert with your rotator cuff just to elevate your arm simply, but especially if you're throwing. And a lot of times the chest wall muscles can tighten up, the muscles can get weak, you may see a prominence of the shoulder blade, and therapy for that. They'll work on getting everything stretched out, getting the muscle strong, and then working on getting the proper mechanics of throwing if that's the issue. But even in a person who doesn't do any sports, regular activities day to day, you're gonna have a problem with that. And a great deal of attention nowadays is put on prevention. You know, back in the old days, let's say they would throw just pitch, throw, no restrictions. Now they're talking about conditioning, proper muscle balance, stretching, building up the proper muscles. You've gotta rest your shoulder if you're particularly a young athlete that's throwing a lot. Number of pitches per game and per week are very important, and there's critical ages where we allow them to graduate the number of pitches, how often they pitch, number of times a week, as well as number of games per week, as well as learning these different pitches. Each pitch sort of stresses the shoulder, but also the elbow and a number of things in a different way. So there's a lot of research being done on that kind of stuff to prevent it. Overuse, you know, we're seeing more of that, particularly in younger athletes. They're playing more sports, going year round. You know, they're joining multiple teams. Not a good idea. You need to vary what you do and break it up a little bit, give the young body a chance to heal, but also the older body, because if you go out all the time, I'm sure you can feel, you play too much, you're going to feel shoulders bothering you, your hips bother you, you got to take care of your body there.